Hi, my name's Ranee Mehra. I'm a medical oncologist. I am at the University of Maryland Greenebaum Cancer Center, and I treat upper air digestive malignancies. So I started my career at Fox Chase Cancer Center in 2006, and since then I've been treating head and neck cancers and thoracic malignancies. So at the University of Maryland, I continue to treat both, and I'm the director of head and neck medical oncology.
Hi, my name is Marijo Bilusic. I'm GU medical oncologist, currently working at the National Cancer Institute. I was trained as a fellow there, and I went to Fox Chase as GU medical oncologist for 4 years, and then 3.5 years ago I was recruited back to National Cancer Institute. So I have two hats there. I'm a program director for a fellowship training program, so I have 40 young hematology-oncology trainees who are going to be future hope of cancer research and care, and 50% of my other time is doing immunotherapy, mostly focusing on prostate cancer and GU malignancies.
Also one of the associate directors of the Bloomberg Kimmel Institute for Cancer Immunotherapy at Johns Hopkins. I'm trained as a surgical oncologist. I'm a physician scientist, so I study cancer immunology and work on drug development to develop cancer immunotherapies.
Okay, so Suzanne, I'll start with you. So what do you see as the most exciting advance in immunotherapy in your specialty?
Well, in melanoma, this has dramatically changed the way that we treat this disease. I would say that 10 to 15 years ago, the expected 3-year survival for a patient with stage 4 metastatic melanoma was only 5%. And now with some of the modern immunotherapy trials with anti-PD-1, anti-CTLA-4 combination therapy, we have 50% of patients with durable survival after treatment. So that's a 10-fold increase in the expected survival for patients with very advanced melanoma. More recently, just 2 years ago, anti-PD-1 therapies were approved in the adjuvant or post-surgical setting for patients with earlier stage of melanoma, stage 3, meaning that the melanoma had spread to local lymph nodes. And this also prolongs the time to relapse in these patients. And so this was approved by the Food and Drug Administration. Now we're looking at giving immunotherapy even earlier in the course of melanoma, giving it before the patient receives surgery. And so it remains to be seen if that will be helpful too. This is in clinical trials now.
So in the GU world, it's kind of interesting there. Like usually we divide cancer into hot and cold tumor, and the prostate cancer is one of the interesting cancer that I'm focusing on my research. It's even though it was the first cancer we had the cancer vaccine therapeutic approved for with sipuleucel in 2010, but it's cold tumor, and checkpoint inhibitors didn't work in prostate cancer. So we are really trying to understand why is that and how we can turn the cold tumor to hot tumor, maybe using the vaccine and combination strategies. On the other hand, we have a kidney cancer and a bladder cancer who are just having checkpoint inhibitor one after another approved. So we have now 5 checkpoint inhibitors approved for bladder cancer. That sometimes makes it difficult which one we select to give it to a patient. And a kidney cancer, which is interesting, moving towards combination with checkpoint inhibitor plus TKI, which was kind of standard. So it's moving from this approach of using with the kidney cancer was a story that interleukin-2 was approved many years ago with its toxic treatment, and there was a mortality in the clinical trials. Not many centers being comfortable and physician treating patient. And now initial was super excitement with checkpoint inhibitors that we thought that's going to be the answer, and then we learned that only 30% of patients will respond to single checkpoint inhibitors. So how we can make this better, and then trials for a combination checkpoint inhibitor plus TKI. It seems that this is the way to go, and the response rates are much higher, and I think we are making dramatic progress.
Wonderful. And Ranee?
Well, I think patients have so many more options now than they did even a decade ago, and in part because of the agents and the immunotherapy drugs and treatments that we have to offer. And, used to be when I was in my training, we were just talking about chemotherapy, and that was the focal point of a discussion when you're trying to plan a new treatment for a patient. And then things shifted a little bit, and you could say, well, chemotherapy, or maybe if you have a mutation, maybe you can get a targeted therapy, but that was still a minority of patients. And now, in one visit, we have a discussion of the range of options from chemotherapy to immunotherapy to targeted therapy to combinations to standard therapy to trials. And I think it puts a lot more burden on us to really be able to explain that well very quickly and to try to help determine what the best option is for a patient. But it's a much more, I think, rewarding experience for the physicians and also for the patients to really have options to think through.
Great. So Suzanne, melanoma's had great progress with immunotherapy, but there's still more to go. Can you talk about what you see as the future in your disease?
Yeah, so in melanoma, we're helping about 50% of patients now, and we need to focus on the other 50%. Not everybody responds to immunotherapy. We do have other treatments that are effective in advanced melanoma, the class of drug called kinase inhibitors. And so there are combination therapies, as you heard, that we're working on. Some of them involve combining different immunotherapies with each other, but some of them involve combining immunotherapy with a completely different form of cancer therapy, such as kinase inhibitors or radiation therapy. And so Dr. Jaffe emphasized this in her talk as one of the things for the future that we all need to concentrate on, and that's what we're doing in melanoma.
Great. So I'm going to open it up to the panel, whoever would like to address this question. What are common questions from patients considering immunotherapy? Does someone want to take a shot at that?
Well, I think the first is, what are the chances that it's going to work? How do you know it's going to work? What is it about my tumor that makes you think this will work? I think that's probably first and foremost on everyone's mind. There is a concern over side effects. I feel like I bring that up more, versus the questions that are being directed to me. But I think that's an important part of the discussion that everyone also has to be aware of.
Anything to add?
So in my practice, the most commonly people, they seek for immunotherapy. It's really a very popular word, and they come and they want immunotherapy. So some of patients, they really have a standard therapy approved, but they really want to go on an immunotherapy clinical trial and trying to educate patients like, well, you have approved therapy which works in 90% of the patient at least, enzalutamide or some target therapy for prostate cancer. You want to try the vaccine we never tried before, and default is probably not going to work. But just because it's so popular, everybody reads about immunotherapy, it's present there. I think it's great to go on a trial, but trying to understand that, maybe it's better to try some standard therapy first, and if they don't work, trying something else, or if it is combination immunotherapy plus standard therapy, all these different things. So just educating patients, having more time, understanding that even immunotherapy is super, super exciting, is not always the right answer. And I think that's the challenge right now.
Did you want to add anything?
I think the approach is going to be different for patients with different types of cancer. I mean, a lot of what we're talking about today does apply across the board to all cancer types. But then you notice that all of us sitting up here specialize in different types of cancer. And so the background in each of those cancer types in terms of what are the standard therapies that are available, when should immunotherapy be used? Should it be the first treatment that you receive for metastatic cancer, or should you receive chemotherapy first or a kinase inhibitor first? And then only if that doesn't work should you go on to immunotherapy. So there are a lot of individual considerations for different cancer types. In melanoma, immunotherapy is considered to be a first option for our patients because this disease is particularly responsive to immune-based therapies, but that might not always be the case. For instance, in prostate cancer, I think there would be a different path.
So I think that leads me to another question that patients often wonder. So when will immunotherapy in these other cancers become a first-line therapy? Do you see this happening in your cancers? You first.
Yeah, so in terms of kidney cancer and bladder cancer, we are seeing the immunotherapy becoming, kidney cancer, that's melanoma, it's very receptive to immunotherapy, so I think it's definitely going to be a frontline therapy. It's already now approved combination, nivolumab, 2 checkpoint inhibitors, given together. With prostate cancer, it's a little bit different story because it's considered cold tumor, still historically is not responding to checkpoint. But I think there are lots of research going on trying to understand biology, why this is cold tumor, how we can make better. We still have very good responses with chemotherapy and hormonal therapy with prostate cancer, so I don't see being frontline immunotherapy with the prostate cancer soon, but I think definitely there are studies doing neoadjuvant treatment when we give the immunotherapy before the surgery and then trying to understand with biopsies. And we are trying to biopsy more, trying to understand tumor microenvironment, because sometimes we measure immune cells in the blood, but it's not the same thing what we see in the tumor. So having biopsy is definitely challenging, and it's not, it's not very exciting. Like patient, like I don't want to get stuck the needle in my bone and drilled. And we are trying to definitely biopsy more, sequence more, try to do molecular profiling, personalized approach. Each patient is different, so we don't treat everybody the same cookie cutter. Everybody is different patient. We're trying to understand biology of each patient.
So Ranee, what about you? Because human papillomavirus is associated with some head and neck cancers. Do you see that immunotherapy is the first line in that?
So that's an interesting question. So, HPV-related oropharynx cancers is certainly a large proportion of the patients with head and neck cancer who we see, and that is a treatment that historically has been very responsive to standard therapies with surgery or chemotherapy and radiation. But those treatments also can have a lot of toxicity and side effects, and so I think as a field we're sort of in this maybe tug of war a little bit between having very effective standard treatments, but that can also cause late, long-term, side effects to treatment, and these newer treatment options, which are very exciting. And we don't want to compromise the good cure rates that we have now, and just go straight to immunotherapy, right? If somebody has an early stage HPV-related oropharynx cancer and chemotherapy and radiation is appropriate for them and can have a very good chance of curing them, I'm not going to not offer that and instead, do immunotherapy, because we don't have data to support that. But we do need to incorporate immunotherapy into earlier stages of disease, and that really requires a much more coordinated effort with our colleagues in surgery and radiation. It's not just up to the medical oncologist in that setting, and the whole treatment team has to be comfortable with doing those types of studies. So, there are trials ongoing now. There are immunotherapy vaccines looking specifically at targeting HPV-related disease. And those are being studied, either immunotherapy is being studied after standard therapy. So we participate in some of our cooperative group trials, and ECOG-ACRIN has a trial right now looking at a immunotherapy checkpoint inhibitor after standard chemoradiation for HPV-related disease if somebody has high-risk features, and there are other adjuvant studies looking more at incorporating some of the HPV vaccines. There are trials giving immunotherapy upfront before surgery. So I think this is just where we really need the data, and those are sometimes harder discussions because, again, without immunotherapy, there still has been effective standard treatments, and we don't want to lose those opportunities as well.
Okay, so what do you feel is the most common misperception regarding immunotherapy? I open it up to the panel again.
So I think because of excitement, the majority of patients may think that this is going to be the answer, like I need to have some immunotherapy and that's going to take care of. And the hope when patients come for, at least in the clinical trial at the NCI, they feel like, okay, we're going to provide the answer and hopefully it's going to work. So it's a lot of disappointment. Like, majority of people will not respond to immunotherapy in the clinical trial settings, at least the tumor type I'm treating. It's like we see like 20% of patients responding. That would be super exciting. And then I think it is, understanding how this works, educating patient, and then possible toxicity that we see. That some patients, they tend not to report and don't pay attention because it's different than the toxicity from chemotherapy and other treatment they're receiving. So I had recently a patient who was on checkpoint, they had like 15 diarrheas, and then he felt, maybe he ate something wrong, and it was very serious toxicity from checkpoint inhibitor that require hospital stay, admission, and treatment with steroids. And just sometimes, trying to really educate patients, like, if you have noticed something different, please let us know, because, it could be a sign of very serious toxicity that sometimes they think, it's nothing to worry about. So I think educating patient, and even though it's some of the immunotherapy we are given, they are very powerful, but then also they can have a different toxicity profile, and then not everybody may be recognizing that at the beginning.
Yeah.
Oh, go ahead.
Oh, no, I completely agree with that. The patients often come in saying, well, this will cure me, and when I offer somebody a trial on immunotherapy, it's not with the goal of cure, and so that ends up being a very difficult discussion, and I keep having to remind myself that we have to also talk about the reality of where a patient may be in their disease, and sometimes I forget that as well, because we're so excited about the treatments that we have and the trials that we can offer. And I've also had patients tell me, well, I'm not going to complain about this side effect because I don't want you to stop this, and sometimes somebody has a very kind of mild side effect, like fatigue, but it's making me worried enough that I said, maybe we should take a break and figure things out. I won't complain of the fatigue, just keep giving it to me. And that's not what I want them to do either. So we really have to, I think, also take breaks when we need to take breaks and make sure we're addressing quality of life and side effects.
Suzanne, do you agree?
Yeah, I agree with the comment that many people don't understand that immunotherapy is not right for everybody. Some patients just automatically, because they've heard so much about immunotherapy in the news and everything, assume that it's right for their cancer, and it may not be. So that's where a conversation with your oncologist is very important. And I recommend for anybody with a new cancer diagnosis to have at least a consultation with an oncologist in a major cancer center or academic center, just to hear about the full spectrum of options, immunotherapy and all other options before making decisions.
Great. So what do you all think patients should think about when they're considering a clinical trial? In immunotherapy, of course. What are the considerations for enrolling into a trial?
Well, there are some practical issues. For instance, if you're going to have to travel to a medical center that's far away to get your treatment, you have to think about how that fits into the rest of your life. How many times a month would you have to be traveling? If you develop side effects, is there a doctor close to home who could help manage that? There are practical issues that we don't think about the first time we think about immunotherapy, but I think that would be one of them, is that especially if you're in a clinical trial, that's really a commitment for patients as well as physicians. Clinical trials are designed to address a medical question, and the trial won't be successful unless patients can stay on the trial and follow the events that are supposed to occur on that trial.
I think in our case, so at the NCI we are a federally funded agency, so we don't charge for our services, and we accept patients from all over the United States, and we have quite a bit of international patients. So in terms of what the problem is with our patient trial is many of them are traveling, they're not local, they are from all over the United States, and then arranging their trips, and some clinical trials are very time-consuming because they're frequent visits, frequent blood draws. They have to be admitted in a hospital for a couple of patients for a couple of days, and it's really impacting quality of life, particularly some people are still working and they have to take days off, and just adjusting their normal life with requirements of clinical trial can be a problem. And then the other issue is when patient goes, let's have quite a few patients like in California, or somewhere else, and there's a toxicity, and how we then communicate, how I make sure patient has access to care immediately if needed. I can fly patient across the country to come here to be treated. So, establishing collaboration with local oncology, local primary care, making sure that the patient has access to care immediately if needed.
And I'm sure there are also cost considerations. The way clinical trials are designed, any aspect of it that's experimental should be covered by the costs of the study. It should not be billed to patients. But increasingly, I think as we have combination therapies, and one drug may be a standard of care and another may be experimental, and some trials still cover everything and others try to have the insurance reimbursed for the standard of care. And then, sometimes insurance companies may or may not agree to do that. And I've had patients who, the insurance companies have said, well, we're not going to cover this standard of care cost because you're combining it with other drugs on a clinical trial. And, those are real challenges that we all face, and we try to appeal that. But I think it puts a lot of stress, certainly on the patient, and then also the entire team trying to figure out how to sort through that. So those should not be things that someone has to worry about when they're fighting a illness. But at the same time, I think that's the reality.
So one more question before we open it up to the audience. So how has immunotherapy changed how you treat patients in your practice?
Well, for melanoma, as I mentioned, it's now a first-line option, and even for patients who have particular mutations where they would be eligible to receive kinase inhibitors, most oncologists and most patients want to try immunotherapy first. So that is a definite change compared to what we had, let's say, 10 years ago, where the recommendation of large cancer boards was that somebody with stage 4 melanoma should just go on to a clinical trial. Like that should be the first option because we didn't have anything else that was really effective at that time.
In GU tumors in bladder and kidney cancer, definitely immunotherapy is becoming frontline therapy. So I think opportunities for patients are much more that, instead of having, this is a chemotherapy option, another option is a clinical trial because there's no second-line therapy for bladder cancer. Now you have 5 immunotherapy FDA approved that they're available for patients. So discussing which one we're going to use, I think it's something that we're talking to our patient. The kidney cancer, same thing. So I think definitely the immunotherapy revolution, how I call it, that there's so many new drugs approved in such a short period of time, it's really giving lots of opportunities for physicians and for patients to offer better treatment. Now, sometimes the challenge then comes, the sequencing, what do you use first, which drug you use first, because there's no head-to-head comparison to tell us, okay, this is better than this one. So we are trying to, work with the patient insurance company and then figure out what's the best next option. But definitely it's dramatically changing the way we practice and giving patient more options, which is always good to have. Because the worst thing is you as oncologists have when you have to tell patient, we don't have no more options available, but it's not like, we have 5 more approved drugs, then it really gives hope, which is very important.
I think definitely we're treating the patients who do well with immunotherapy. We're treating them longer, and they have a good quality of life during that time. And so I think it's been, a rewarding time to be an oncologist because you can actually have, a relationship with your patients that spans years, which is, definitely been an evolution in the field.
Great. So I'm going to open it up to the audience for questions. There's one back there. You'll be soon.
Can another immunotherapy be used when you have side effects to maybe Pembrol, Bismol, whatever, or Keytruda? Can you use another immunotherapy?
You can, I actually can't see you because, there we go. So sometimes depending on how severe the side effects are, if the side effects are mild, sometimes okay, so for just in a general comment, if the side effects are, okay, so the general approach is if the side effects are mild, we can usually treat through that with careful observation. If the side effects are quite severe, then we have to stop giving the anti-PD-1 and treat the side effects. Depending on what the side effects are, sometimes we can try to start the anti-PD-1 therapy again. There's some risk to that because the same side effects might come back. So it really, it really all depends on how threatening the side effects were that led to a pause in the treatment.
Okay. There's also a question up here when you get a chance.
Can you discuss the association between adverse events and the patient's response to immunotherapy? Thinking of your Dr. Topalian's recent paper, the 5-year follow-up. It seemed to me you had positive responses in patients with grade 3 and 4 adverse events.
Yeah, that's absolutely right. We just published this several months ago in the journal JAMA Oncology. We did a long-term follow-up where we took 270 patients with melanoma, kidney cancer, or lung cancer who were treated on one of the very earliest trials of anti-PD-1, nivolumab, and we just asked the question, where are these patients now, and can we find some characteristics in these patients that would have predicted that they would have prolonged survival. So, in fact, we found that the patients who had side effects related to the therapy were more likely to be alive 5 years later. Now, this was maybe a little bit unexpected because you would think side effects are undesirable, but actually there is a mechanistic link between the side effects that we see, which are inflammation in normal tissues, as Dr. Jaffe described earlier, as a kind of a spillover effect based on the mechanism of the drug. The drug is liberating immune responses. We want it to be directed against cancer cells, but sometimes there's a spillover. So maybe these side effects just mean that the drug is very active in that patient. But there is definitely a link there because we showed it in hundreds of patients in that study.
Let me just ask one follow-up to that. So for patients being treated for adverse events with long-term steroids or immunosuppressants, do you see a turn-off of the response at that point?
Yeah, so that's a very interesting question. So if we start the steroids to treat a side effect that occurred on anti-PD-1 therapy, that does not seem to interfere with the outcome, and we've published that in other studies. But if patients are on significant doses of steroids before they ever start getting anti-PD-1, that will reduce the likelihood that they will have a good outcome. And that's been published by others. Yeah.
This gentleman here, right there.
Okay, sorry.
Question is for Suzanne. I've been a caregiver in numerous cases. I've seen differences in treatments, outcomes, effects on patients. I'm curious with melanoma especially, what the difference in the process is and how it affects the patients between the past process and what you're finding with immunotherapy.
I'm sorry, the difference in melanoma between?
I'm looking at it from a patient perspective.
Uh-huh.
What they have to go through, what happens with the previous process and with the process that's happening with immunotherapy. How does it affect the patient?
Sure. So with other kinds of therapy for melanoma, I mean, each therapy has its own unique kinds of side effects. For instance, 15 years ago, there was one form of immunotherapy that was approved for melanoma, and that was high-dose interleukin-2. But this is a very toxic therapy. It only helped about 12% of patients with metastatic melanoma. Now, the people who were helped survived for a very long time after they received the drug, but many of them had to be in the intensive care unit while they were on treatment to manage their side effects. So that was a very different kind of immunotherapy. The immunotherapies that we're talking about here today, the anti-PD-1 drugs, those are all outpatient treatments. So the patient comes to the outpatient clinic, they're there for a couple of hours to get their infusion. If all is well, they go home until the next time that they have to come back. We started giving these drugs every 2 weeks intravenously, then it was every 3 weeks, now it's every 4 weeks, and for some of them it might even be extended to every 6 weeks. So that's in clinical testing right now. So in terms of the time commitment and the severity, the intensity of the treatment, that has really been brought down a lot. So I think it's a much more livable treatment now for patients. Yeah.
Renee, can you mention for lung cancer, which is another cancer that responds, what do you think? What's the answer to that question?
Oh, so not that long ago, the standard first-line treatment for lung cancer involved chemotherapy doublet, carboplatin, and Taxol. That was the combination that was used for many, many, many years. And Taxol can cause neuropathy. You lose your hair with Taxol. And I think that was kind of the picture of every newly diagnosed lung cancer patient. It's a treatment that can have a lot of fatigue, risk of infections. And now we have even options of, in the first-line setting, giving immunotherapy even without chemotherapy, depending on the profile of the tumor. And one of the patients at Fox Chase who I treated on a clinical trial with an immunotherapy combination years ago, she didn't, not that I'm advocating for that, but she didn't want her sphere, her social sphere to know that she even had the disease. And she didn't have any outward side effects. Her hair was still the same style that she always had. And she, that was how she chose to have her cancer journey. But she had that choice, right, where that was not something that people had before.
Great. Another question?
I have a question about prostate cancer. So where are you now into turning this cold cancer into the hot cancer? The second question. Okay. The second question is, do you know how instead of biopsy you can use the wet samples? Where are you at it now? Because I know there were some study done trying to look, instead of going into the bones, just to use the blood samples. So where is it now? And also I know that now, it's like a proposition, instead of using only one treatment, you use two kinds of treatment, so cancer doesn't have a chance just to get it's difficult for them to adjust, let's put it this way.
Yeah, thank you for the question. So the way how we divide cancer, it's cold or hot, based like on the biopsy, looking how many inflammatory T cells are there in the tumor biopsy. So when you do the prostate cancer, there are not many T cells there. So if there are not T cells in the prostate, in the tumor, there's no unlikely that they are going to have immunotherapy is going to work. So there are studies that trying to we're trying to learn how we can make this inflammation happening there and how we can deliver T cells to the tumor and try to turn it to a hot tumor. So vaccine is maybe one of the answers, adoptive T cell, or some other approaches have been tested. In terms of combination therapy for prostate cancer, it's definitely the way how the field is moving. So initially, standard treatment for newly diagnosed metastatic disease was hormonal therapy for several years till cancer convert to hormone-resistant disease, and then additional treatments were started. And in 2015, there was a pivotal trial called CHARTED, combined chemotherapy plus the hormonal therapy, and shows significant improvement in survival in people who have high-volume disease, and that was confirmed with the European study called STAMPEDE. And then additional studies were done since then, like LATITUDE and other TITAN, showing that some second-generation hormonal therapy, in addition to standard LHRH agonists, which suppress the secretion of testosterone, can work and improve survival. So definitely the treatment paradigm in prostate cancer is shifting towards combination therapy, as you indicated. And the third question about liquid biopsies, we try to use the circulating tumor cells, but this is not standard care yet. We don't have strong validation. I think the research is going towards that direction that we can identify, but there's still work needs to be done that we can validate the markers, we can validate the approach, and I think outside the clinical trial it's not applied to a clinical practice. In some tumors it's more advanced, like in breast cancer, I think they're more advanced than in prostate cancer. But I think field is moving towards that direction, trying to do liquid biopsies and try to learn. And I think in lung cancer, I think liquid biopsies are more advanced than in prostate cancer. But I think that's where field is going. Doing biopsies really is difficult, and particularly with prostate cancer, everything is the bones, and yield of those biopsies is very low. It's like 30% of patients actually can have some tumor tissue. Otherwise, it's when you have to do decalcification of the bone, then you kill some tumor. So it's really lots of a struggle with us and for the patients as well, trying to learn about molecular profiling and genetic morphology.
Good morning.
Good morning.
Immunotherapy works with all cancers?
Good question. Who wants to address that?
So unfortunately, no. And even within a specific diagnosis or type of cancer, it doesn't work for all types. So for instance, for lung cancer, even though it's FDA approved and for lung cancer and with multiple drugs and multiple time points in someone's disease, there are certain lung cancers that don't really respond to immunotherapy, and there's a proportion of lung cancers that have specific mutations that drive the cancer, and we know that those ones don't respond as well to immunotherapy, and you know, that's just one example. So it really is specific to diseases, and even within a disease, specific to the features of the particular cancer.
So when someone come to you, and did I hear you say that you have consultation therapy? Did I hear that? That there's a part where you do consultation therapy with the person who comes to be interviewed for the trial? Well, my question is, once the person is selected for the treatment, do you find that a relationship between the medical field and the person who is receiving the treatment works better when the patient and the medical field, whoever's treating them, is positive and get along? That helps with the treatment?
That helps no matter what treatment you're on, right? Yeah.
You
That's
said it helps
essential.
with no matter what treatment they're on?
Yeah, you
Yeah.
want to have confidence in who's
Yeah.
treating you, and you
Yeah.
want to feel like you can talk to them. I think that's a really great question you're asking, because if it's a partnership
Yes.
in this disease, as you're pointing out, I think.
Yes.
And that partnership means that you have to feel comfortable telling the healthcare team when you're not liking what's happening,
Exactly.
you know, and the problems. And if you don't feel comfortable, then that's not good. So
Okay.
that's a great point.
Thank you.
We have one here too after.
Yes. If you have another, for immunotherapy, if you have an if you have an immune suppressive disease like an immune IBD or something like that, is that contraindicating to an immune therapy? I've been told both ways. And does it automatically exclude that immune therapy might be available?
Great question. Who wants to address that? Suzanne?
If the question is about autoimmune diseases?
You have to have a baseline autoimmune disease.
Yeah. So it depends on how serious the autoimmune disease is, but if it's a disease that requires high doses of steroids or other immunosuppressant drugs, it may be too dangerous for those patients to receive immunotherapy.
What if you're on maintenance therapy?
If patients are on low doses of steroids as a maintenance therapy, sometimes it is possible to treat them with immunotherapy. But as I mentioned earlier, there have been publications recently showing that the response of the cancers in those patients might be at a lower rate than what we would expect in patients who don't have to be on those kinds of treatments.
What about non-steroids maintenance?
Drugs that are more powerful than steroids?
Non-steroids.
Yeah.
Acetol or something like that.
Yeah, so I don't think that we have enough specific information on all of those treatment types. Most of our patients would come to us being on a maintenance dose of prednisone, for instance. I think that would be most common.
So you would find that out?
Absolutely. Very important to know that. Yeah.
Question over there and then over here.
Hi, good morning.
Go ahead.
Good morning. I'm a stage 4 lung cancer patient. I never smoked, and I've been living with this for 4 years now. I've been on immunotherapy. March 2nd will be 4 years being on immunotherapy. So my question for you is, when March 2nd comes, should I keep going as long as the cancer's still stable, or when do you stop?
Yeah, that's a really good question. obviously.
I feel blessed. I'm sorry. I'm so blessed. So I just wanted to know.
Yeah.
Should I keep going or do I stop? I'm sorry. I don't want to cry. I'm sorry.
I think the fact that that's a good problem to have, right? That we have that question in front of us, and I think that's where we still are really trying to learn, like how long patients need to stay on it. I don't know that we have like the answer, and some of it is probably specific patient to patient. And so that's where, back to the point of having the relationship with your care team, like that's some of the difficult decisions, right, that you have to have with your physician, because that's the person who probably knows best what's been going on with your.
Wonderful.
Yeah.
I'm very blessed to have a wonderful care team.
Yeah.
And a wonderful oncologist.
So I think that's something that that it really is like a face-to-face, in-depth discussion with risks and benefits, and then deciding from there. And even if you go down one path, like you always have the chance to relook at it, right? Depending on what's going on.
Yes, because I always look for Plan B just in case, but I hold on to my faith and. 4 years strong, so God is good. Thank you.
Can immunotherapy be used as a vaccine for cancer suspected to be in remission? So can you boost my immune system to prevent the cancer from reoccurring?
Great question.
That's the idea behind what we're trying to do by treating earlier stages of cancer. So as I mentioned before, now in melanoma, anti-PD-1, 2 different anti-PD-1 drugs are approved to treat people who have had all of their melanoma removed surgically but are at high risk for relapse, meaning that somewhere in their bodies there are microscopic deposits of melanoma that are too small for us to detect on CT or PET scans. So we think that we're going to surgery to remove all the cancer, but there are some microscopic deposits that we're not able to detect at the time. So yes, it's been shown in large studies and now with FDA approvals that in melanoma, if you give anti-PD-1 drugs after surgery for patients who are at high risk for relapse, that you can prolong the time to relapse. And we're now awaiting the survival information from those studies. So these are fairly recent studies.
But I'll add to that, because I think where you're going is, if you're at high risk, can we prevent the cancer? At least I think that may be.
High risk of recurrence.
High risk, okay. So, but even.
More unknown if it's actually in remission.
Right. Okay, so then I think that was a great answer. But we're also thinking about, can we even predict who's going to get cancer and eventually prevent it? So with human papillomavirus, I don't know how many of you had your kids vaccinated, but that prevents a lot of cervical and cancers, and it prevents head and neck cancers long term. That's a situation where someone hasn't been exposed to the agent causing the cancer yet, such as a virus. Human hepatitis B virus vaccine prevents liver cancer. So we're already preventing some infectious associated cancers. And the goal is to learn more about how would we prevent cancers in high-risk families where we know that there are genes involved as well. So that's a longer goal.
Along with that, how can you sequence my tumor if you can't see my tumor now?
We can't. So the goal would be to sequence the original tumor. But again, it could change when it comes back. So it would be better to wait at this point. It's very hard to consider a vaccine at this point. But if it was right after your treatment, let's say surgery or chemotherapy, we could use the recent cancer to try to make an educated guess. But it would still be a guess, and it needs to be done in a clinical trial. I think last question. We're almost out of time.
Hi, I am a cancer. I'm a lung cancer stage 4. I have tried different type of immunotherapy, Keytruda, Opdivo, and nothing has worked for me. So I'm back to chemo. But I understand there's a Nivolumab that was for stage 3 before. Are they going to try to create that for stage 4? Is it nivolumab immunotherapy?
Right. Yeah, so durvalumab is an immunotherapy. It's a similar class of drugs as the nivolumab and the pembrolizumab. So, there's how the drugs are different, based on their properties, but then a lot of how we offer it to patients really depends on how it was studied in the clinical trials. And so durvalumab, I think you're referring to the trial where it was looked at in patients who finished chemotherapy and radiation, and it was very successful in that setting. Just because it was successful in that setting, in that trial, doesn't mean that it would work better than the pembrolizumab or nivolumab in the setting of somebody who has metastatic disease. Because the differences between how those drugs are used are really more related to what population they were studied in the trials. I don't know if that's clear. Yeah, I know probably not the answer.
Development for nivolumab for stage 4?
So there are trials, certainly, and looking at combinations. I think, the pembrolizumab and the nivolumab are two good options already in stage 4. So rather than durvalumab alone in stage 4, probably what's of more interest is looking at combination studies for somebody who's already been on immunotherapy.
Immunotherapy, I believe, Odiva and nivolumab. At first it was Keytruda only, and then it worked. Then the old one goes down, the new one pops up. And then my doctor tried the off-the-book immunotherapy, did 2 immunotherapy, Odiva and pembrolizumab. And some goes up, some goes down.
Yeah.
So that's why she put me back on chemo again.
Yeah. So we, with the area of probably research now, and what we really need to focus on is what are the resistance, why is it that it goes up and down, and understanding more about that resistance then would help to develop the trials specifically in that setting. And there are trials out there, for lung cancer, for patients who've been on immunotherapy before who hasn't worked, but it still is an area that we need a lot of research on. Absolutely.
And targeted drugs.
Again, it depends because it's such a heterogeneous disease. It really depends on the specifics of of your individual disease, but there's certainly for patients who've already been on immunotherapy, combination studies, some of the cellular-based therapies, and even incorporating chemotherapy and some of our more traditional therapies. But now lung cancer is a disease where we traditionally sequence. You want to know what mutations are there. You want to know what the mutation burden of a tumor is. So a lot of factors come into play before deciding the next step, especially when somebody's already been on immunotherapy.
You know what? We're over time. I'm sorry. So I think in the interest of time, there's going to be plenty of time to ask additional questions at lunch or in the sessions that follow. So I think rather than delaying those additional sessions, why don't we stop here? And I want to thank all of you for participating in great questions. I want to thank our panelists for participating today. Thank you very much.